Hi everyone. I am back tonight. It's Wednesday night and I am waiting for Dr. Kathleen Gould to join us. We're going to be talking about hypochondriasis, which is the old name for, we'll talk about it in a minute. So let me just add her on. How's everyone doing tonight? Okay, it says it's adding, so I'll just take a second. Hi.
Hi.
How are you?
Nervous as I can possibly be, and I am reminding myself that these are all my friends, okay?
Absolutely.
Yeah.
You're going to do great. I've seen Dr. Kathleen Gould. I've seen her speak in person before. We met last year, I think, or the year before at a conference, and she was wonderful. So I have no doubt you're going to do great.
Thanks, Christina.
Yeah. And so I just wanted to start by, as always, reading Dr. Gould's bio. So Dr. Kathleen Gould, MD, is a graduate of Rush Medical College and the MGH McLean Psychiatry residency. After completing her training, Dr. Gould worked as an inpatient attending on McLean Hospital's Trauma Disorders Unit. She returned to Rush in 2011, where she served on the Consultation Liaison Service in the outpatient clinic and as residency training director. Currently, Dr. Gould is affiliated with Wellsprings Health Associates in Chicago.
Yep.
So thank you for joining us tonight. And please tell us, take it away. Tell us what you're going to be talking about tonight.
I'm going to be talking about a study that was published in August of 2017 in the American Journal of Psychiatry. The study is called a randomized controlled trial of medication and cognitive behavioral therapy for hypochondriasis. The study authors, because they deserve credit, Brian Fallon, David Ahern, Martina Pavlikova, Jordan Slabov, Natalia Skritskaya, and Arthur Barsky. So, but first I want to start with very briefly some context, because what if you do a great big study and then they eliminate your diagnosis that you were studying? The recruitment for this study began in 2004, which was well before, the DSM-5 was published. And basically, it was from 2004 to 2009 that they did recruitment. Part of the thing that makes it difficult for researchers is because patients with hypochondriasis, many of them have poor insight. And so many of them are seen in medical circles, but not in, presenting to a psychiatrist for help with anxiety. So it was hard to recruit for this study. And then, here we are. So because the diagnosis has been eliminated, I do want to go quickly back to talk very briefly about the changes in the DSM-4 to the DSM-5 so that we can contextualize this diagnosis and treatment for ourselves as we proceed to think about this study.
Great.
So hypochondriasis was in the somatoform disorders section. Yes, I have my notes here, yes. Somatoform disorders section of the DSM-4. And other disorders were somatization disorder, undifferentiated somatoform disorder, conversion disorder, pain disorder, and body dysmorphic disorder. In the DSM-5, as we've discussed, the diagnosis of hypochondriasis was eliminated, and the whole section was renamed as somatic symptom and related disorders. Conversion disorders as an illness of medically unexplained symptoms was continued in the DSM-5, but other disorders were reconceptualized as disorders of health-related distress, or in the case of body dysmorphic disorder, as an obsessive-compulsive and related disorder. The major disorders now present within the somatic symptom disorder section are somatic symptom disorder, illness anxiety disorder, conversion disorder, psychological factors affecting other medical conditions, et cetera, unspecified, not otherwise specified. Factitious disorder is also included in the somatic symptom and related disorders now, and it had its own section in the DSM-4. So, even though they eliminated the diagnosis, there are still patients with this kind of distress. So we need to see how hypochondriasis maps onto the new DSM-5 conditions in order to consider how to apply the results of this study. Diagnostic criteria for hypochondriasis in the DSM-4 were preoccupation with fears of having or the idea that one did have a serious disease based on the person's misinterpretation of bodily symptoms. The preoccupation persists despite appropriate medical evaluation and reassurance. The belief about having a serious disease is not of delusional intensity. The preoccupation causes clinically significant distress or impairment, and the duration is at least 6 months. The DSM-5 in its introduction to this section says that 75% of patients formerly diagnosed with hypochondriasis will meet criteria for somatic symptom disorder. That's the one that I've just described. About 25% of patients have high preoccupation with health fears in the absence of somatic symptoms or with only mild symptoms. An important difference between these two disorders is the presence or absence of significant symptoms. Hint, hint, hint for the CME questions. Very briefly, the major criteria for illness anxiety disorder include preoccupation with having or acquiring a serious illness. Somatic symptoms are not present, or if present, they're mild in intensity and the preoccupation is clearly excessive or disproportionate. There's a high level of anxiety about health and the individual is easily alarmed about their health status. And the individual performs excessive health-related behaviors or maladaptive avoidance. I'm just hitting the major highlights. I'm not doing all of the exclusions. And the criteria for somatic symptom disorder include one or more somatic symptoms that are distressing or result in significant disruption of daily life, and B, excessive thoughts, feelings, or behaviors related to the somatic symptoms, including this and persistent thoughts about the seriousness of the symptoms, high levels of anxiety about the symptoms, and excessive time and energy devoted to the symptoms. Now, this is in the presence of at least moderate to severe symptoms. So I also want to highlight that as the DSM-5 was being prepared, there was some consideration of putting hypochondriasis into the obsessive compulsive section of disorders, because one of the symptoms was preoccupation about health persisting despite appropriate medical evaluation and reassurance. And that's very similar to the intrusive thoughts of OCD, which persist despite reassurance. However, instead of moving it, they kept it in the illness-related symptoms category, and they eliminated that concern persisting and worry persisting despite reassurance. They eliminated that from any of the symptoms in this category. If you've treated any of these patients, you know that the anxiety persisting despite reassurance is definitely still there no matter what the DSM-5 says. So paraphrasing the authors, talking about the study, enough about the DSM-5. Hypochondriasis is a common and distressing order with significant functional impairment and associated high levels of healthcare utilization. And this is true with both of the new disorders that the DSM-5 talks about. Cognitive behavioral treatment has been shown to reduce the symptoms, as has other psychotherapies or adaptations of CBT. The authors cite 2 randomized placebo-controlled trials with SSRIs. One of them was with fluoxetine, and the other one was with a comparison of paroxetine and CBT, where the outcomes were similar for the SSRI and for CBT. As an aside, there has also been one small study back 100 years ago when Dr. Gould was a girl and dinosaurs still roamed the earth, of tricyclics with this tricyclics for this condition, and tricyclic antidepressants were found to be beneficial. So the primary aim of the study was to determine the efficacy of pharmacotherapy and CBT, both individually and together, for hypochondriasis. The team also hypothesized that joint treatment would be similar. Joint treatment or combined treatment would be similar to the individual modalities, and each individual modality would be superior to placebo. So this was a 24-week study where 4 treatment conditions were compared. And I'm going to collapse some of the data and rearrange it. So the treatment conditions that were compared were CBT treatment with a scripted manual that's been used in prior treatment studies. Patients had face-to-face 60-minute sessions every week for 6 weeks. It was followed by 2 biweekly visits and 3 monthly booster sessions. Fluoxetine treatment with medication management visits was the second arm of the study. The medication management visits were delivered on the same schedule as the CBT visits, so weekly for 6 weeks, etc. They were 20 to 30 minutes in length. The visits were also manualized. Content was limited to clinical status review, medication compliance, side effects, and any intervening illness or medications. Medication was administered on a fixed, flexible dosing schedule beginning at 10 milligrams a day and increasing up to 80 milligrams based on patient preference and clinician judgment. So I want to just notice the constraints of the study, because this isn't how you would do medication management if you were doing it alone. You would start the patient on, more than 10 milligrams. You'd probably go up faster, and you wouldn't see the patient weekly. You would see them maybe monthly or 2 to 4 weeks and keep increasing across the whole 12 weeks. And you would across the whole course of the illness, where you just wouldn't be seeing them at the beginning. But they had to have a comparator that included equal contact, so they wouldn't be thinking that the CBT patients got better because they had more care and attention. Everybody had the same face-to-face care and attention. So controlling for the effect of contact with a healthcare provider did, in my opinion, slightly distort how one would ordinarily do medication management. But you can't design a perfect study.
Right.
So the third arm of the study was placebo treatment with medication management. So the patients in the placebo arm had the same schedule of visits, and they were the medication management visits as described for the active arm. And the fourth arm of the study was individuals in the combined therapy and fluoxetine group. They had CBT treatment and medication management visits as previously defined. Participants were recruited by advertisements and professional referrals. They had a structured diagnostic interview for hypochondriasis and a medical evaluation to enter the study, because guess what, if they had a real illness, that would, we wouldn't want to be treating them for hypochondriasis. The inclusion criteria were outpatient status between the ages of 21 and 25 years, DSM-4 diagnosis of hypochondriasis of at least moderate severity, and if there was a comorbid psychiatric disorder, hypochondriasis had to be earlier in onset, judged to be the more severe disorder, and was the predominant source of distress. Exclusion criteria: psychoactive medication use in the preceding 2 weeks, the presence of an unstable medical illness, lactation, pregnancy, or absence of contraception in women of childbearing age, current medication that might be unsafe to combine with fluoxetine, any comorbid DSM diagnosis rated as severe, a history of psychosis or bipolar disorder, current suicidality or suicide attempts in the previous 6 months, and symptom contingent litigation or disability and workers' compensation proceedings. Now, what's the purpose of that? The course of these illnesses is worse where there is symptom contingent litigation or disability or workers' compensation proceedings. And I'm not going to comment on the reasons for that, but this is just known. Participants were stratified into those with and without comorbid major depression or dysthymia, and members of each group were randomly assigned then to the 4 treatment conditions. So there was an extensive battery of tests that were administered at the beginning of the study, and then at the end of 6 weeks, at the end of 12 weeks, and the end of 24 weeks. And I'm not going to go through all of those in the interest of time. The primary outcome ratings were the Whiteley Index, which is a 14-item self-report questionnaire of health distress, and the Hypochondriasis Y-box, so the Yale-Brown Obsessive Compulsive, say that 3 times fast, Yale-Brown Obsessive Compulsive Scale for Hypochondriasis Modified, which is a semi-structured interview rating of hypochondriacal thoughts, behaviors, avoidance, and insights. Very similar to the Y-box for OCD. So they used both a self-report scale and a clinician semi-structured interview, and combined both of those to consider the outcome. The responders were had to meet a 25%, at least a, now I'm fumbling through my papers, at least a 25% improvement over their baseline scores, both of those, in order to be considered responders. At the end of 12 weeks, patients or study participants that had not had at least a 12% rating, 12% improvement, I could be wrong about that percentage, forgive me, were released from the study in order to pursue different treatment because it wasn't helping them. So now we'll talk about the results of the study, if I can get my papers back together. Forgive me for that. Okay. I'm never going to print on double-sided paper again for one of these things.
That happens to me all the time too. And
Yeah,
then you have to like flip the papers back and forth, and yeah.
Yeah, and then it's where am I? So, okay, keep calm and carry on. All right, I'm back together now.
Sure.
So then they didn't find what they hoped to find, straight up. And they did a couple of analyses about these. They did a trend analysis because they didn't find a significant difference between the responders in each group. So they had to do, they didn't find the outcome that they hoped that they would find, that the benefit of combined treatment would be at least 150% of any individual treatment. They did a trend analysis saying that the hypothesized pattern of response was present, that combined treatment would be better, but it trended towards significant, but it wasn't clearly 150% better of either one by itself. So,
which I feel like is an unusual finding, right? Because I feel like it's almost always that combination treatment is going to be additive and, you know, improved
right,
over single treatment.
And that's what we find with depression,
Right.
right? CBT for depression plus meds, people are going to get way better, way faster.
Right.
Okay. They didn't see actually, what they did find was fluoxetine was superior to CBT and to placebo. CBT and placebo were not significantly different in this study, which is bizarre, right?
Mm-hmm.
But the trend was towards significance, and the combined treatment was better, but not whoppingly so.
Yeah.
And the other thing that they found was that of the responders, the responders in the fluoxetine group improved at a greater rate than the responders in the placebo group or the CBT group. Anybody who was treated with fluoxetine got better faster, although the outcomes weren't substantially different at 24 weeks. People got better earlier in treatment faster if fluoxetine was included. So the study overall supports the conclusion that fluoxetine was the primary treatment contributing to improvement. It was significantly more effective than placebo, had a significantly faster rate of improvement, and higher doses appeared more effective than lower doses. The other thing was, okay, so they did two analyses. They did an intent to treat analysis where all of the participants were evaluated, including the participants that were released, at the end of 12 weeks because they weren't responding.
Mm-hmm.
And then they did a secondary analysis of the participants that survived to the end of the study, and those were the responders, to see what had happened. And for those people, the fluoxetine treatment was more effective than placebo, and the combined treatment was also more effective than placebo. The fluoxetine group had the most responders compared with the joint treatment group, although that wasn't very significant. It was 81% of the fluoxetine group, 62% of the joint treatment group, and 51% of the CBT group, and 44% of the placebo group. So that's not what any of us would have expected. I would have expected a more robust CBT response over placebo. I would not have expected that fluoxetine would have a higher proportion of responders than fluoxetine plus CBT. That doesn't make any sense at all. The the question, I think the most interesting question is how to account for that.
Mm-hmm.
And okay. The other thing is that percentage of responders is a different measurement than degree of response.
Right.
And efficacy. So those numbers are different. And that showed a higher degree of improvement from both treatments, and then fluoxetine. So the question is what they're actually measuring. And I'm inspired by the editorial by Catherine Phillips in the same issue of the journal. As we think about these things, they may have hampered themselves by considering how they would measure improvement. Because if you think about it, as I think about it, functional status and excessive participation in medical treatment and evaluation and health-seeking behaviors is as much of an issue as the cognitions. Standard CBT that would have been focused on health-related cognitions might not be what changed first, with medications, and then behaviors might not have changed, with CBT as much or at the same thing. So I think that they really hampered themselves by requiring a 25% improvement on both scales. I think they should have tried to have a different outcome measure for when they're comparing two treatments that might be affecting different aspects of the illness. Catherine Phillips, do you see what I'm saying by that, Christina?
Yeah.
You have to stand in for everybody.
No, I do. And actually, somebody else is commenting. Michael Hackman is commenting that he agrees with the functional status thought, and they should have also potentially analyzed healthcare cost difference, which is kind of what you're saying. So involvement in the medical system. Absolutely.
Right. And I might have, if I had done the study, considered a 25% response on either scale as responder rather than requiring both, given that the treatments might be affecting the illness in different ways. Catherine Phillips wonders, the average fluoxetine dose was 40 milligrams, or in the area of 40 milligrams in the Boston arm of the study, and 30 milligrams in the New York arm, which is interesting. But wonders if she is one of the proponents that this is an OCD-related illness, and we typically use higher doses of SSRIs. She wonders if the dose had continued to go up until the symptoms were eliminated or we reached a maximum dose, if the outcome of the study might have been different. Also, she wonders if some of the CBT treatments, such as exposure and response, prevention, exposure without reassurance, might have, the CBT treatments that we offer for OCD might have been added to get a different kind of a response, and more improvement. the good news about this study is that a lot of people got better. Um,
Yeah,
about
that's reassuring.
Yeah, a lot of people got better, and a lot of people got better quickly. In about, look, 6 weeks later, there was substantial improvement in everybody. 12 weeks later, there was, including the placebo, which is interesting. So I don't know what the natural course of this illness actually is. But that goes, to the standard of our recommendation for these kinds of illnesses is regular visits with a primary care doctor. It's an interesting question, actually, along the same lines. What we recommend for these is frequently regular visits with a primary care doctor to just kind of keep everything under control. And that was basically similar to the placebo arm of the study. So I'm thinking that's why there was such high benefit for the placebo arm, is it's actually similar to one of the treatments that we recommend for this condition. So,
Yeah, I've always wondered too if people with hypochondriasis are more susceptible to placebo than other patients or people with other illnesses, just by the nature of
um,
their, because I don't
that
know.
is, that's really smart.
Yeah.
Yeah,
So,
yeah.
and I think, again, it seems like you and Michael Hackman are kind of paralleling each other because he commented again about whether he's actually asking if patients were allowed to see their PCP for workups or if their PCPs were involved at all during the study.
Um, I don't recall any
Yeah.
comment about that whatsoever. They
Yep.
had a workup at the beginning of the study, and actually there was a relatively high dropout rate as well. And maybe that was the reason that people
Mm-hmm.
couldn't stand it, and they went to go see
Yeah.
their PCPs for more of a workup. Hi,
Yeah.
Michael Hockman. Hi. Great minds think alike. Yeah.
Well, thanks. I mean, this actually gives me a lot, something to think about because this isn't something I typically think of as treatable or easily treatable, but it makes me a little bit more hopeful. So,
Yeah,
thanks for, yeah.
because half of people had a good
Mm-hmm.
response
Yeah.
and a sufficient response to improve their functional status,
Yeah.
I think. Yeah.
So good.
So
And
yay.
thank you for going through the article, and thank you for the nice analysis afterwards too. And actually, Dr. Gould will be joining us, I believe, in a week or two. I have to look at the schedule on another article on, I believe, DBT. Is that right?
Yes.
Yes.
And I'm
So,
going to print everything up on a single side, not double-sided. So I really appreciate the opportunity. I really appreciate that you set this up for all of us. This is really great. It's an opportunity to feel connected to colleagues, and
yeah.
I
Well,
appreciate the chance to do it, Christina.
yeah, not at all. And by the way, guys, Dr. Gould is in Chicago, and she's now at Wellsprings Associates, and is taking new
Yeah.
patients. If you guys, are looking for
Thank
somebody in the
you.
Chicago area to treat,
Yeah.
she's wonderful. So I would highly recommend as a
Thanks,
colleague.
Christina.
Yeah, and
Thanks.
and guys, if you are watching this video and haven't seen the other videos, remember these can all be found in the group. Just use the hashtag Journal Club. Email me at psychiatrynetwork@gmail.com to be added to our mailing list. And, yesterday, just kind of as an aside, I did post to see whether anybody was interested on being a blog contributor to our new website, which should be coming out in a couple of weeks. I'm really excited. And I think I had like 40 or 50 people respond, which is crazy. I really didn't realize there would be that much interest. So I'm trying to respond to everybody and kind of keep it organized. So I'm getting to those as soon as I can. But thank you, everyone.
And you're doing all of that and getting taking care of your child.
Yes, and setting
doing
up
your
our,
doing your day job,
oh
setting up a
yeah, that too.
setting up a conference.
Yeah, so,
So
but
hey,
I love
yeah,
this group. I love everything that's coming out of the group. So,
yeah. We're all
yeah,
very grateful
yeah.
to
All
you.
right. All right, guys, have a good night. And thanks again to Dr. Gould. And we'll see you guys next week, Monday at 7:30 p.m.
Bye. Thanks.
Take care. Bye.